All right, so we're going to get started with our afternoon session. Thank you for attending. This session is the concurrent session on engaging patients with diabetes facing many challenges and many costs. My name is Dr. Fatima Cody Stanford. I'm an obesity medicine physician scientist at Harvard Medical School and Massachusetts General Hospital. I'm part of the American Medical Association Governing Affairs Council and also part of the inaugural Top 40 Under 40 for NMQF. I will be moderating today's session, and what I'd like to start off with is going through the bios of our esteemed panelists today. I would also like to say to our panelists, I will be fierce in making sure that we stick to our guidelines. You can see we have a large panel of very esteemed individuals. After I introduce them and once they get engaged, I will give each of them 5 minutes with which to address their issue, and we will make sure that we have meaningful discussions surrounding diabetes and its impact on minority communities with specific focus on the African American population. I will start off by introducing Bruce Taylor. Bruce, if you can raise your hand for me. Bruce is a healthcare veteran with more than 35 years of experience in senior sales, marketing, health policy, and advocacy positions within pharmaceutical manufacturers, chain pharmacies, managed care, and medical device manufacturers. Bruce has extensive experience within numerous therapeutic areas that include cardiovascular, gastrointestinal, burn care, diabetes, lipids, and the central nervous system. Bruce co-founded the Diabetes Care Project with the National Minority Quality Forum to address the worldwide epidemic of diabetes and the impact to local, national, and global communities. He actively participates on the advisory boards for the ADA, ACE, CWD, AADE, the Endocrine Society, the National Minority Quality Forum, and the AMGF. He is a highly regarded expert in the area of diabetes. He also himself was diagnosed with diabetes over 30 years ago, and he has earned his Bachelor of Science from Baldwin Wallace College, his postgraduate degree in cardiac physiology, and he is also a world-class powerlifter and qualified for the 1980 Olympic Games. Just in case you guys wanted to know about that, Guillermo, Amezcua, am I saying that? Oh, fabulous. He's the Senior Director of Marketing and Pricing for Baxter. He is the U.S. peritoneal dialysis commercial lead for Baxter Healthcare. As part of this role, Guillermo is responsible for the PD product portfolio, therapy programming, patient support and services, as well as the pricing and new business models. His primary goals for the business include accelerating growth of peritoneal dialysis therapy by increasing access to Baxter's new platform, AMEA, with ShareSource. He has been with Baxter for nearly 11 years. We have spent time managing different aspects of Baxter's business from a marketing, operations, and finance standpoint. Prior to joining Baxter, Guillermo worked in investment banking. He earned his MBA from the Kellogg School of Management and a BA in economics from DePauw University. All right, so that's Guillermo. We're on to Karin. Karin, if you can raise your hand. Karin is an Associate Director of Public Policy, leading the Changing Diabetes Policy function at Novo Nordisk. She serves as the co-chair for the Diabetes Advocacy Alliance and the U.S. project lead for Cities Changing Diabetes. She's also responsible for developing and leading research that underpins Novo Nordisk's diabetes advocacy work. Previously, Gillespie was the senior consultant for Lane, Howard & Associates, a Philadelphia-based healthcare strategy firm. She has been published in numerous professional journals and authored a book on shaping healthy eating habits in young children. She holds a BA in psychology from Princeton University and an MBA degree from the Wharton School. So that's Karin. Marie Brown. Dr. Marie Brown is a practicing internist and associate professor in the Department of Internal Medicine at Rush Medical College, senior physician advisor for the American Medical Association, and immediate past governor of the Northern Illinois chapter of the American College of Physicians, also known as ACP. Her national leadership roles have included member on the board of directors for the American Board of Internal Medicine, operations committee for the National Diabetes Education Program, sponsored by the CDC and NIH, a member of the State Quality Improvement Organization Board of Directors. Dr. Brown is a frequent guest lecturer and panelist in academic, national, and international healthcare conferences. Her areas of expertise include medication adherence, diabetes, practice transformation, joy in medicine, adult immunizations. Dr. Brown received her Bachelor of Science degree from the University of Dayton in Dayton, Ohio, and her medical degree from Rush Medical College. Thank you, Dr. Brown. I will move on to Dr. Rita Kalyani. Am I saying that correctly? Dr. Rita Kalyani is Associate Professor of Medicine at the Johns Hopkins School of Medicine, core faculty at the Johns Hopkins Center on Aging and Health, and associate faculty at the Welch Center for Prevention, Epidemiology, and Clinical Research. She graduated with an undergraduate degree from Harvard College and completed her medical degree, residency, and fellowship at Johns Hopkins. She also obtained a master's in health sciences degree in clinical investigation from the Johns Hopkins Bloomberg School of Public Health. She's an active clinician. She sees patients regularly within the Diabetes Center at Johns Hopkins, as well as attending on the General Endocrine Consultation Service. She directs the Diabetes Management Service for Johns Hopkins Total Pancreatectomy Islet Auto Transplant Program. That's a mouthful. She is NIH funded for her research, which focuses on diabetes and aging and investigates accelerated muscle loss, disability, and frailty in older adults with diabetes. She is also a fellow of the American College of Physicians and serves on the National Steering Committee called the ACP Quality Connect Diabetes to improve the quality of diabetes care. She's co-founder and editor-in-chief of the Johns Hopkins Diabetes Guide for Healthcare Professionals, available both book and electronically as a mobile application, now with close to 200 topics. So thank you. And last but not least, Dr. Marilyn Fraser. She is the Chief Executive Officer of the Arthur Ashe Institute for Urban Health and Assistant Professor in the Department of Medicine at SUNY Downs State Medical Center and the co-director of the Brooklyn Health Disparity Center. In her previous capacities as the Deputy Director and the Associate Director for Research and Training, she was primarily responsible for overseeing the Institute's community outreach and research programs. Dr. Marilyn Fraser is a graduate of the Spartan Health Sciences University of Medicine in St. Lucia, West Indies, where she maintained an enviable scholastic record. During her medical education, she was afforded the opportunity to be exposed to various types of healthcare delivery systems within the United States and abroad. Her medical training has included work in the West Indies, Mexico, and various U.S. cities, including Kansas City, D.C., and New York. She's a former scholar of the NHLBI-funded Summer Institute program to increase diversity. I'd like you to give just a round of applause to all of those wonderful panelists and their great. So just to give you an idea of what we're going to focus on, because we actually have a very minimal amount of time to cover a large healthcare issue of diabetes, we're going to have different people on the panel focusing on different issues. Bruce specifically will talk about his leadership as the co-chair of the Diabetes Working Group and Equity Task Force, and as a patient, he'll talk about what we're doing and why it is so important. Dr. Kalyani will do a brief summary of the ADA standards, which she is the lead author of, and she will focus on issues surrounding disparities. Dr. Marie will look at the importance of adherence and understanding the disease issues around adherence, why and how to respond to them. Dr. Fraser will do community work, look at community work in this space, and specifically look at her role at the Arthur Ashe Institute. Karin will talk about her work in Houston and globally and at the community level, specifically focusing on Cities Changing Diabetes Initiative. And Guillermo, I don't know this little tidbit for you, but I assume you're going to do some fabulous things also. So what I'm going to do is I'm going to go actually in the order of the panelists. Some of them have prepared PowerPoints. They will keep that to 5 minutes. But Guillermo, I'm going to have you start with your 5 minutes, and I will be timing this. So I will step aside. All right.
Very punctual.
Okay.
I'm also the least qualified panelist today. But that's okay. That's the story of my life. There's a place for C students, everywhere in this world. So I do my best. So look, I am Guillermo Amezcua, and I represent Baxter Healthcare. It is a large company based in Deerfield, Illinois. There's a lot of Illinois presence, and I grew up in Indiana. So Dr. Adams probably represented me at some point in my life if we crossed paths at that time. So it's great to be here. I want to thank everybody for making time for this very important topic and for giving Baxter an opportunity to discuss what we do to manage the link between diabetes and dialysis. So my business in particular represents dialysis patients, so patients that perform either hemodialysis or peritoneal dialysis. However, the one that we care about very significantly, because it is so underrepresented in the US, is peritoneal dialysis. And peritoneal dialysis is dialysis that's done at the home typically. There is typically a catheter inserted in somebody's belly, and fluid is drawn out and put back into that patient's body each day to take all the things out that the kidney is unable to do on its own. So, if I just advance here, the link is very clear because 40% of dialysis patients also have diabetes. Okay, so that means that today, if 10 patients start on dialysis, 4 of them will also have diabetes. So they're managing 2 things. So they already got that first punch of you are a diabetic patient, followed then by the way, now you need to start dialysis. And so what we're trying to do is make sure that we can address something that is very tragic in the US. And that's the fact that planned starts, which means that you have been seeing a nephrologist. Somebody has been helping you to manage and to delay the onset of your dialysis, is helping you to make sure that you have an understanding of what you can do to manage that so that you don't become a dialysis patient. And so when you actually manage your health and you plan your start, if you do end up on dialysis, 50% of the time people will choose peritoneal dialysis. Now, what that means is that of the 20% or so of people that end up on dialysis and end up on dialysis through a planned start, 10% of them overall, right? So 50% of the 20% end up on peritoneal dialysis, and that's the US national average for the patients that are actually utilizing peritoneal dialysis. Other modern countries, westernized countries, have 40, 50, 60% peritoneal dialysis use. A state in Mexico, Jalisco, which is in the west central part of the country, has 60% peritoneal dialysis utilization. Some markets only reimburse for peritoneal dialysis, but yet in the US, it is only 10%. And let me tell you why. Because the majority of Americans crash into the system. So what that means is you had no idea that your kidneys were failing. Your endocrinologist, your primary care physician never linked you up with your nephrologist, with a nephrologist that said, hey, look, there's 2 basic exams that we can look at. We can look at the protein in your urine, and we can look at how well your kidney is actually filtering out bad things that the kidneys need to do. If we do those 2 things and monitor them and manage for your symptoms, we can make sure that if you do face a dialysis decision, you're well aware of it before you crash into the emergency department. Because here's what happens. Nearly 100% of those crashes end up on hemodialysis, which means that you are at a clinic 3 times a week, your blood is being filtered, your lifestyle has changed, your family dynamic is completely different. So 80% of people who start dialysis in the country today either end up on dialysis through crashing into the system, they end up in the emergency room, CV catheter in their neck, or the doctor says, hey, listen, we've started you on hemodialysis, here's the clinic, here's your nephrologist, on you go. So that's the status quo of the system today. And what we believe that peritoneal dialysis brings to patients, other than the clinical reasons, I'm not a physician, but just trust me that 80% of patients who start dialysis can be clinically diagnosed to be treated with peritoneal dialysis. And there are some clinical advantages to peritoneal dialysis as well as it relates to early preservation of your kidney function when you begin dialysis. But let's ignore those for the moment and let's just look at some of the social aspects of what peritoneal dialysis can bring. So macroeconomic factors. A dialysis patient will cost, a hemodialysis patient will cost our country about $80,000 more than a peritoneal dialysis patient because that patient will receive 2 to 3 more services per year. They will also be on additional prescription drugs. They will require additional transportation to and from the clinic 3 times per week. And so there are major macroeconomic impacts to our market. From a microeconomic standpoint, there are certain things that a patient needs to do to alter his or her life. So if you look at a patient-specific dynamic lifestyle changes, so you may or may not be able to work any longer.
I'm going to cut him off just because I love him, because we have so many fabulous things, but we're going to pick this back up in the discussion.
Absolutely.
All right?
Absolutely.
Okay, all right, but
Let me just highlight that locally we're working to raise awareness and education around peritoneal dialysis with the NAACP, with the American Diabetes Association, with other groups, because as Dr. Adams talked about, these non-traditional groups is really the way to carry this forward. So I'm over time. Thank you very much.
All right. I told you I would be a fierce sticking to the rules. So I have Dr. Marie Brown. I'm going to bring her up to have her 5 minutes with us. Keep in mind, there will be time for discussion. So Guillermo still has fabulous time left. We just want to make sure we get to everyone, okay?
Thank you, Dr. Stanford. I am truly honored to be here and want to thank Dr. Hall and Dr. Puckrin for the opportunity. So as you heard, I am an internist. I see patients almost every day, the vast majority of whom have diabetes, hypertension, and in the past, most of whom did not take their medicine. If they were uncontrolled, the majority were not taking their medicine as prescribed. And over a decade ago, the World Health Organization said that improving medication adherence would have a far greater impact on the health of the population than any improvement in any specific medical therapy. We have wonderful treatment out there. We can prevent kidney failure. We can prevent stroke. But as you see here, 50% of patients do not take their medicine as prescribed. And over 25% don't pick up the initial prescription, and in diabetes, 40%. And we see that over time, the persistence goes down and down and down. Even in patients who've had a stroke, what most of us say we fear the most. And yet even those patients are not taking medicine that will prevent another stroke. But when you talk to our providers, and I was one of these until I saw the light, and that was that physicians and clinicians think that my patients are adherent, not me. My patients, I know that I care for them deeply. They tell me they're taking their medicine when in fact they're not. Yet if you survey patients, the vast majority would not tell their clinician that they are not, have no intention of starting the medicine. Now, why could this possibly be? If you look at, and you ask clinicians why their patients are not taking their medicine, the vast majority, and maybe you in the room would say, well, they don't have access, or they can't afford it, or they forgot. Those are important reasons, but those are the minority of reasons. The vast majority of patients, and you have some in your family, maybe you're thinking about your own medication-taking behavior, but you know that many of your family and friends are not taking their medicine as prescribed because they choose not to. And that is hard for us to understand, and it's very important for us to listen to our patients to understand because they have very good reasons, very valid reasons for choosing not to take their medicine, and we have the challenge of bridging that knowledge gap. And I'll end with this list, that although forgetting and access and cost and shift work are important and unintentional causes of non-adherence, the vast majority of our patients with diabetes and hypertension are choosing not to take their medicine, often because of mistrust, because of the legacy of Tuskegee, the fear of side effects, listening to daytime television and hearing what could go wrong with that drug, with a long litany, and the last one being and death, right? Mental illness. A huge number of our patients with obesity and diabetes have depression. We cannot begin to address adherence or get that A1C or blood pressure under control until we identify the depression and treat the depression. Lack of feeling that it will benefit them. Most of these are absolutely asymptomatic. They don't feel any different if they take their medicine, and in fact, because we don't listen to our patients clearly enough, they feel worse when they take their medicine. And isn't all drug dependency bad? Isn't that the campaign in my neighborhood? So Dr. Brown, are you telling me that I'm going to have to be on this for the rest of my life? I don't want to be dependent on a drug. Right? These are common things we hear. Really fear it's dangerous, a lack of desire, and really that asymptomatic condition, no benefit. And the last that I'll end with is that altruism. We as physicians talk about professionalism, and one of the tenets is altruism, to put the patient before our own needs. Well, many of my patients with limited resources have the money to either get their medicine or take that money and sacrifice and give that to their grandson who needs something for school, a new book, a new backpack. The other issue that we need to contemplate is that many of us in this room are, we have delayed gratification, right? We have more degrees, and we are the poster children for delayed gratification. But many of our patients do not feel they have a future to look forward to. So we have to tailor our message. Thank you.
Thank you. Thank you so much. So thank you so much, Dr. Brown. So keep in mind, we're doing good on time here. We're going to go to Dr. Marilyn Fraser, who will come up and have her moment in the spotlight.
So I do not have a PowerPoint. Good afternoon, everyone. It's wonderful being here. So I would like to talk a little bit about the Arthur Ashe Institute for Urban Health and the work that we do. It's something that I love talking about, so I'll try to keep it within 5 minutes so I don't get a hook from the person down there. So the institute, the Arthur Ashe Institute, was founded by Arthur Ashe just about 2 months before he passed away. And Arthur Ashe founded the institute at SUNY Downstate Medical Center, so we're a community-based academic organization. So we were founded at SUNY Downstate Medical Center in Brooklyn, and it was founded to address certain health disparities. And we do that through a variety of ways. Health promotion and health education was a tenet of what Arthur wanted us to do. Also paying attention to make sure that we are training the next generation of health professions. So we do that through a health science academy where high school students come to SUNY Downstate and they learn about health issues and they learn about diabetes. They have an endocrinology class and they learn about all of those different aspects as well. Health disparities is something that we have paid quite a bit of attention to. So the Institute partnered with SUNY Downstate Medical Center and the Office of Brooklyn Borough President, which is a unique community, academic, and government partnership to address health inequities in Brooklyn. And we have done that with our community engagement work within beauty salons and barbershops, where we go to meet people where they are, to train folks so that they are able to talk to their customers and deliver health messages to their customers about health issues. We know that policy is very important, and we cannot do this work without trying to inform and change policy. So it's vital for us to make sure that we have the legislators also on board, that they realize that things such as diabetes and cardiovascular disease, those are important. They're plaguing our communities very much. We are disproportionately affected by these issues, and so that we have to make sure that that is done. I want to talk just a little bit give you one of the quotes that Arthur left with us. And he said, to achieve greatness, we need to start where we are and use what we have and do what we can. And so at the Arthur Ashe Institute for Urban Health, we do just that. We're starting where we are in Brooklyn, in communities that are disproportionately affected by health inequities, addressing diabetes, addressing cardiovascular disease, HIV/AIDS. If you were to name it in our communities, we find it. So going to people where they are, using what we have, those partnerships with community-based organizations, some of which are at the table over here, and I'm glad that they were able to come out today, partnering with academic institutions, partnering with those personal care businesses, partnering with beauty salons, barbershops, faith-based organizations, and going there to do what we can, and making sure that we can raise awareness, we can conduct research to find out more about the disease, finding out what the community thinks about things, and that we're able to inform policy to make sure that we make a change that could be sustainable. Thank you.
Well, that was delightful. Look at that. I had to come up to the stage. Thank you very much. So I will now have Karin Gillespie, who is with Novo Nordisk, come and speak with us.
Good afternoon. I'm delighted to be here. I'm Karin Gillespie with the public policy team at Novo Nordisk, and I'm the U.S. project lead for Cities Changing Diabetes. And Cities Changing Diabetes is a global program of Novo Nordisk. It's now actually in more than 12 cities across the world. There are another 8 cities that are in the process of exploring coming on board. Houston was actually the 3rd city to come on board in November 2014, behind Copenhagen and Mexico City. This program is intended to address, I'm not able to, there we go. This program is intended to address the day-to-day challenges that people have living with diabetes, particularly those who live in urban settings. And the catalyst for it was threefold. One being increasing urbanization, the second being increasing diabetes prevalence, and the third being really trying to understand the community level vulnerabilities or the social determinants of health that affect people living in cities. And looking specifically, for us, looking specifically at Houston, which is in fact the most diverse city in the United States. Where we live influences how we live, how we work, how we eat, how we play. And living in a city, in particular, influences this, urban areas as well, but we decided to focus on cities because that was where there were population centers. And the overarching model for Cities Changing Diabetes is actually very simple. It's map, share, and act. But how it's implemented, working with stakeholders at the community level, is where there are nuances and where it gets messy. We didn't go into Houston with the idea that we understood what the problems were around diabetes or what the solutions might be. We really went into Houston to work as a partner, to work with the city, and to help the city look at diabetes through a different lens, to look at diabetes through community level vulnerability. We also wanted to be a catalyst for convening the stakeholders, who they themselves would come together to brainstorm, to develop, and to implement solutions. The Houston Health Department was our partner, and we started talking with them in 2014. It was a lot of back and forth until we were perceived to be a credible partner. And as you can see here, we have multiple layers of stakeholder engagement. So we have our anchor partner in the health department, but then we also have stakeholders who represent a broad range of different groups in the community, working with employers, working with health systems, working with health plans, working with faith-based and community-based organizations. So really trying to bring people together across disciplines. I'm going to just back up here a second if I can. In mapping the community level vulnerabilities in Houston, we worked with the University of Texas School of Public Health, and we went right to where the people were. We went to their houses, in their neighborhoods. We did 125 in-depth interviews, really trying to understand what the vulnerabilities are in Houston. And what we found were these risk profiles, and we also found that there were a group of vulnerabilities that crossed Houston, and those were financial constraints. They were perceptions of change and transition in one's neighborhood, so really making people feel socially isolated. Unhealthy food traditions that might be nourishing from a cultural perspective, but unhealthy in terms of what people actually are eating, so kind of some of the nuances around that. Long commutes by car. If any of you have visited Houston, you know, and Joy is one of our stakeholders who we work with in Houston. We can't start meetings in Houston early in the morning because people can't get to the meetings because they sit in traffic. And then also just an overall sense of time poverty. So people are grappling with balancing caregiving responsibilities, work, commutes, and so they can't prioritize their personal health. So what we did was organize the stakeholders into action work groups. They self-organized, actually, and then around a lot of these themes. And they came up with solutions that would address the gaps and the needs. And through 2015 and into 2016 and 2017, they met, they brainstormed, and we now have 5 projects that are actively moving forward. One of them is in fact a website that we call the Houston Diabetes Resource Center, where we've organized materials related to diabetes from across the city that were curated by the American Diabetes Association and American Association of Diabetes Educators members who live there in Houston. We also trained navigators who could help people navigate the system. We also worked with houses of faith from across the city, shoring up their health ministries. We found that they were in fact fragile, so we've done some training to shore them up. And then we have 3 other initiatives that are in progress, and hopefully during the Q&A I'll have a chance to tell you a little bit about those. I'll just end by saying that in 2017 we received a grant from the Robert Wood Johnson Foundation that also went to UT School of Public Health to be able to evaluate the program. So they are in fact looking at Houston, Vancouver, and Mexico City to kind of work to extract best practices and learning. So look forward to answering any questions and sharing a little bit more. Thank you.
Thank you so much. I would like for Dr. Rita Kalyani to come forward.
Great, thank you. So I have the privilege of giving you a perspective from the healthcare provider. You've heard about disparities in the community from the patient perspective, and one of the ways we can impact healthcare is really educating our healthcare providers on the issues that many of our patients face and providing them evidence-based guidelines to manage patients with diabetes. And so what I'll be speaking about today is the Standards of Medical Care in Diabetes that is published by the American Diabetes Association. I had the privilege of chairing this committee this past year. For those of you who are not familiar with these clinical practice guidelines, they are published every January in diabetes care. They're a 150-page document that are revised annually for our healthcare providers to reference and really strive to incorporate the latest and greatest evidence and to grade the evidence so that healthcare providers know exactly what to do when they're managing their patients. Now, some of you who are healthcare providers in the room may or may not look at clinical guidelines, and so we see this as an educational tool for those who use it. But I will say, in 2017, 700,000 people access these guidelines. These include healthcare providers, patients, third-party payers, others from industry and pharma. And so they're really an opportunity to impact the care, particularly of vulnerable populations. So just as a disclaimer, and this is the official slide deck from the ADA that's freely available online. The standards of care are also freely available online for those of you who might be interested. These are funded out of the ADA's general revenues. They do not use industry support. They correspond with sections within the actual document. They're reviewed by the ADA Board of Directors as well. And the Professional Practice Committee is the committee I sat on that conducts the annual review and revision of these guidelines. So we searched Medline, or PubMed, for human subject studies related to each subsection and published since January 1st, 2017 for the 2018 update. The recommendations were revised as per any new evidence for clarity or to better match the text or the strength of the evidence. And that's the website if you're interested in downloading it. In 2018, the Standards of Care is the only clinical practice guidelines issued by the ADA. In the past, the ADA had position statements on particular topics, but beginning in 2018, this is a primary source. So this is the Professional Practice Committee, and that I'd like to acknowledge all of my committee members from a wide variety of specialties. You can see we had nurse practitioners, CDEs, dietitians. It's really meant to represent the comprehensive care of the patient with diabetes, and of course our staff at the ADA as well, who were vital to having this published. This is the grading system that is used in the recommendations. A, of course, is the highest. It's based on randomized controlled trials primarily. B is based on well-conducted cohort studies. C, studies that are good but may have some methodological flaws. And E is expert consensus. So I am not going to go through the 150 pages of the document, but really want to focus on those recommendations that I think will inform our panel discussion. And these really stem from our first chapter, and there's a reason it's the first chapter. It's because it sets the context for how we treat the patient with diabetes. And it is titled Improving Care and Promoting Health in Populations. So I'm going to skip ahead to a care delivery systems, just to point out the extent of what we're dealing with. So in a study that came out maybe 5 years ago, statistics haven't changed though, about 33 to 49% of patients with diabetes hadn't met targets for A1C, blood pressure, or lipids. And one of the things I want to point out as well is in these standards, we set the standards for language that we use with people with diabetes. We don't say diabetic patient. We don't say pre-diabetic patient. We don't label the patient with their disease. We say patient with diabetes. And so you'll hear me say that throughout the presentation as well. Only 14% of patients met targets for all 3 of these metabolic goals. And it was clear at that time that progress in cardiovascular disease risk factor was slowing. And we know that system-level improvements are needed. We can treat the patient at the individual level, which is very important, but the system level has to change as well. And we all know that the delivery system is fragmented, often lacks clinical information, capabilities, and that there's often duplication of services. So that's really what we're talking about here today. So we have multiple recommendations for system-level improvement, but what I want to focus on is the social determinants of health, which I think will be most relevant here. And so we added a recommendation for tailoring treatment for the social context. So this is a level A, so based on solid evidence recommendation. Providers should assess social context, including potential food insecurity, housing stability, and financial barriers, and apply that information to treatment decisions. So we know that many of our populations face these very pressing issues, and we can sit in the healthcare clinic and manage patients as much as we want, but until we understand the social context, patients aren't going to go home, take their medication, and they're not going to do as we prescribe. So I have a few minutes. All right, so refer patients to local community resources when available, or maybe 10 seconds. 10 seconds, 10 seconds. All right. So, and provide patients with self-management support. So the last thing I'll leave you with is that when we educate patients, it really has to be tailored to their needs. We have to speak to them in a way that they understand, that really recognizes the social context. And I think we'll get more into that in the panel discussion as my time is nearing. But I really want to emphasize that even our clinical guidelines for healthcare providers acknowledge that. Thank you.
Thank you. All right, so I'm doing this, I want the panelists to know is I'm doing this so that they can delve and really speak with the audience, because you guys are here to really get information back. Mr. Bruce Taylor, last but not least, I would like to invite you to give your 5 minutes.
Watches are synced. Did you put the slides in, Laura, that I sent you this morning? Okay, well, we can wing it. There's a recent publication that came out in the American Diabetes. It was called The Cost of Diabetes in 2018. It is one of the most alarming pieces of literature you could read. 70% of all the costs for diabetes is preventable. Those are hospitals and the cost of medications that treat the comorbid conditions of uncontrolled diabetes. We just heard about dialysis. 40% of uncontrolled patients with diabetes end up in dialysis. I'm not a rocket scientist, but let's stop. Part of the challenge is when I got a call from Laura and Gary is to say, hey, we're going to start this thing of sustainable healthy communities. We need your help. We want you to co-chair this. In my professional life, I work with advocacy and things with a company called Dexcom with continuous glucose monitoring, but most of my time I'm advocating on behalf of patients to have access to the tools, medications, and things that they need to individualize their care to get there. So it was like, okay, one more go around. Gary and I worked together in South Texas and McAllen, Texas, and it was a fairly heavy lift, and now he's saying, well, we want to do 3 cities. Well, now if Gary and I showed up to your house to move furniture, you'd be pretty happy because the size of the 2 of us, we're not going to drop anything. But this is going to be a pretty heavy lift. But now I'm going to transition because you're talking about me. I was diagnosed 38 years ago at my Olympic physical. I went to see my physician. You know what he told me? Son, you need to exercise more. I'm training 3 to 5 hours a day, 6 days a week. There was nothing left in the tank. I said, how about some drugs? But when you're talking about the patient, I'd like to provide some basic insight into the psyche of a patient with diabetes. First, it's not an easy diagnosis to get. 2, quit telling me what to do, but teach me how to do it. It's like saying, I'm hungry, well, there's an ocean with a lot of fish, but you don't give me a fishing pole. You don't teach me how to cast. You don't teach me how to count carbs. I don't need diabetes education, I need diabetes literacy. I need to understand survival skills. The best advice I got from a dietitian, when it comes to food, anything white is bad. So the bread pudding and that little cream sauce, you hearing me? That was at least 8 units of insulin, but it was good. But see, as the patient, how do you help me with survival skills? I'm not a professional diabetic. I am a practicing diabetic who likes to live. And I need to incorporate diabetes in my life with medications that are personalized for me, with technology that supports my lifestyle. After 38 years, I do not feel low blood sugar coming on. So I have a device in my pocket that beeps or vibrates that lets me know it's coming. It's also synced to my 2 adult daughters and my wife, who are all in healthcare. And I don't know where they got their sense of humor, but my youngest daughter, when my blood sugar rose to 200, Dad, I hope those carbs were worth it. Or my daughter that calls me at 2 o'clock in the morning because I travel globally. Dad, are you okay? Your blood sugar's at 65. Do you have the stuff you need with you to take care of that low blood sugar? I'm the one diagnosed, but don't forget my care system and my family. Because if you don't incorporate them in the care team, but we're talking about patient engagement, you need to recruit me and my 30 million other sweet people. Yeah, we're sweet. Some days sweeter than others. You need to recruit us to be on the same side of the desk, because if I am not engaged, your healthcare outcomes will not improve. I am a practicing endocrinologist, but I never went to medical school. I've got one patient. Some days he's good, some days he's not so good. Some days he's frustrated. But from a patient perspective, recruit me to be a member of your team, and I got to be the quarterback. I'm going to give you a figure. 99.983% of the time, I am managing my diabetes. That other little fraction of the time is when I'm spending time with my diabetes educator, my endocrinologist, or my primary care physician. So I'm alone. Empower me, enable me, and give me the literacy to be my own endocrinologist. Thank you.
I'd like to thank all the panelists for giving us a flavor of their work as it surrounds diabetes, the care of patients with diabetes, and their desire to achieve system-wide change related to the care of persons that struggle every day with diabetes. I'd like to open up the conversation to the floor. Nestor is here at the mic. Please address your question to the panel.
My name is Nestor Ramirez. I'm a retired neonatologist from Champaign, Illinois. I very much appreciated what everybody has said, and I liked especially what Bruce just said, because I'm a diabetic myself, and I had some of the bread pudding.
You said 8 units. Eight units, Nestor.
Yeah, and I appreciate the thing about the support and the family, because When I left the hospital after I was first diagnosed, they gave my wife a whip, and she keeps me under control. She's not here today, so fortunately, but she keeps me under control, and due to her, I've lost 45 pounds in the last 8 months. But my whole point is about something Dr. Brown mentioned and Dr. Kalyani mentioned, and it's the fact that there's noncompliance because of confusion and sometimes because of ignorance. I think patients are sometimes very confused because they hear on the TV that this medication is to lower your A1C. A1C is not a condition or a treatment or a disease or something that you treat. You should lower your blood sugar to keep a low A1C. It's only measured every 2 or 3 months anyway. So people don't really take care of themselves. They wait till the 3 months and see what happened to their A1C. There's a disservice to the patients by having those commercials on TV that tell them that this is what you're supposed to control, your A1C, not your blood sugar.
So tell me this, I wanted to make sure I had a question specifically for the panels. I think maybe you want them to specifically address advertisement, which you think may dissuade patients from seeking the appropriate care.
Yes, since all of them talked about information and about having the patient know about their disease and stuff, I think it's a disservice to tell them to check their A1C or this is to lower your A1C, not to keep control of your blood sugar. So I think if all of you in the different advocacies that you have could make sure that these kinds of misinformations don't happen. You can always say, lower your blood sugar, and that will maintain a good level of A1C. I had an A1C of 10.8 when I was diagnosed, and the last one they measured in March was 5.3. But that's not what I was striving for. I was striving to have a normal blood sugar.
Okay, got it. Did anyone on the panel want to speak to his comments? Yes, Bruce, you can.
As a patient, I think one of the challenges is, in this room, we speak in medical jargon. We speak about A1C. My brother's a mechanic who is also diagnosed with diabetes. He doesn't have a clue what that means. Now, you talk about hydraulic pressure, he's with you. But sometimes we forget and we have to speak with the patient where he or she is at in the most basic of terms. Anything white is bad except for cauliflower. Okay, I get it. That's an epiphany because it was a level of understanding. And how do we break that down? Because we're so accustomed to speaking in our medical jargon, we know what we're talking about, but the poor patient started going, oh, I have no idea. Well, are you talking to me? Well, then talk to me. Talk with me.
Anyone else in the panel?
Yes, I couldn't agree more. And we could try to educate everyone with diabetes and prediabetes, but we could also take some time to educate ourselves and to tailor that message. We have a long way to go. It is very humbling, and you practicing physicians and clinicians out there, if you go back to your practice and ask your next 2 patients what their sugar should be in the morning and what it should be after they eat and what a normal A1C is, and even more important, what should their blood pressure be, they have no idea. And here we are striving, and with the EHR, we have these metrics that slap us in the face every morning. So the gap is tremendous. And I say it's challenging to educate all our patients, but we have to look at ourselves first. I have a mechanical engineer who's a daughter, and I did some health literacy work with support from Dr. Hall in the past, and learned that highly educated people thought that metastatic is it good or bad? I said, it's good. So I went home and I said, Julia, is metastatic, what does that mean to you? And she said, well, let's see. In engineering, I took static, it's not moving, and then I had to take dynamics. She goes, yeah, I guess metastatic would be good. So it was very humbling because it's very thoughtful, but it's very humbling, and we have a lot of work to do internally to improve how we communicate. That's our fault.
Absolutely. I do think that the panelists bring up very important points about how we perceive people understanding the types of things that we think are very commonplace, things about like what your sugar is, what it should be, what's your A1C. These are things that we immediately can bring up numbers. If I were to ask multiple choice question, but most everyone in this room would be able to answer it correctly. But what does that mean for our patients? What does that mean for your brother who's a mechanic? What does that mean for your daughter who is a mechanical engineer? I think these are extremely important. Karin, I think you wanted to say something in response to that comment also.
Yeah, just kind of looking at it from the city level, from working with the stakeholders in Houston, one of the things that was very clear that came out in the research was low diabetes and health literacy. And then we heard quite clearly when we were working with the community, when we pulled the action work groups together, and we also did a series of roundtables with patients and with employers and others, and what we heard is that they wanted some kind of a website that they could go to that would house resources related to diabetes, but what they wanted in addition to that was they wanted a live human being that they could interact with who would be able to link them to resources in the community. And so that was one of the first things that we actually worked on broadly in Houston, was to create this Houston Diabetes Resource Center and link it up with navigators who actually were trained in AADE's diabetes paraprofessional training. So they could look at the website and then talk to somebody and get linked to both clinical and community-based resources to help them with their diabetes.
Absolutely. Now, I see people at the mics. I want to go to this mic over here because we started over here. Can you tell me your name and where you're coming from? What your question is?
Good afternoon, thank you. My name is Caitlin Denny. I'm the Executive Director of the Prince William Area Free Clinic, based locally out of Woodbridge, Virginia. And in brief, I have 2,000 plus patients at my clinic, 90% which have a chronic illness, 25% of which are diabetic, mostly type 2.
Hold on, I just want to stop you for a second because Dr. Kalyani brought up a very good point about people first language with diabetes, meaning we don't call them diabetic, they have the disease of diabetes. I appreciate you for acknowledging that during your presentation. So I'm just going to change that language just a bit there, and then I'm have you going.
I appreciate that, thank you. Of my patients, of some of whom are diagnosed with diabetes and are dealing with this, as it was mentioned, at a family level, I'm a mostly volunteer organization, and of one of my 15 staff positions, we have a diabetic coordinator. And yet regularly my patients have A1Cs of 18, and they don't take it seriously until they've lost multiple toes, or they have an ulcer the size of a fist in their foot. And until I'm called in to be, you need to go to the ER or you're going to lose your leg. So my question to you is, as we continue to talk about non-traditional actors that we're partnering, and we're going into cities and we're developing with personal care businesses, among others, what are we doing to tie in free clinics? Those of us who are doing what we can on the ground, where my endocrinologist is 3 hours away, and where my primary care providers are doing the best they can with education that may or may not be updated. What's being done for partnerships for those of us that are acting currently?
That's a very good question. Who would like to take that on the panel?
I can begin.
Guillermo, thank you.
So one of the things that we need to do, and I think we're connected this way on the dialysis side, is we actually need to provide funding for groups like yours and create networks where we can link things up, because what we can do is create a platform, but we can't execute locally, and that's one of the things that big organizations like mine have, I would say, stumbled with in the past, where we thought we could do something center-led and have a big impact locally. It doesn't work that way. And so what I would say is this, there's obviously a lot of groups here today, and I think what unites many of us is the fact that literacy, I think a lot of times comes from patients speaking to patients. Because there is a general, when you talk about minorities, there's not always a mistrust, but there's a skepticism that comes with, the physician said, do this or don't do that. Well, why are they saying that to me? Well, do they say that to other people? Well, I don't know who to ask. But if you know other people who are local, who may be seeing the same physician, who may be going to the same grocery store, the same church as you, and understand that, you're not in it alone, I think those things can go a long way. And so those peer programs become very, very important. Facilitated by or coordinated with, obviously, medical oversight. So you need a nurse practitioner, a nurse, somebody like yourself, or physician to make sure that the content and the discussions are appropriate, but linking up patients to speak with other patients so that that message can resonate. I think that's that literacy that the team is talking about, and I think that is common in dialysis and diabetes.
Yes, Rita.
So I just wanted to add to that. I think someone made the comment earlier that a lot of us like delayed gratification in this room with all the degrees, but I think, when we talk about a chronic disease like diabetes, it's really delayed complications, kind of seeing what you do now and how it impacts your risk of complications in the future. And that can be really hard to see until you actually have a family member who had an amputation or you know someone who had a complication. I think one of the things that we might need to do better just as a healthcare system is applaud the steps. We always focus on targets. I'll just speak from the healthcare provider side on targets, but really any improvement is better than where you started from. And so one of the things that we do in our healthcare system, in our clinic, is really applaud the steps. You went from 10 to 9 within 6 months. That's really great, as opposed to, well, we need to get you to 7 or whatever your metabolic targets are. But I think seeing people who've gone through it, having that peer group, I think you're asking a larger question about resources that perhaps some of the other panelists can talk about. But I think even as healthcare providers, there are ways that we can talk with the patient to encourage, to motivate them, and really see what they're doing in a stepwise way can lead to a delay in complications in the future.
Yes, Dr. Fraser.
Yes, and so it's a very important point because I think a lot needs to go into that in terms of resources and making sure that resources are available, whether it is putting more funding into community health workers or patient navigators, making sure that people are linked to services. When we go out into the communities, a lot of people we say have a regular hairstylist and a barber, and they don't have a regular primary care doctor. So the messenger is important, who are they listening to? And I think that's where the peer group plays such an important aspect of that. But making sure that we are creating networks where we can link people to services. Oftentimes, when we go out into the community, we want to make sure that there's a clinic or something that we can actually sometimes take a patient to. And if we tell them to go there, they may not go. So having someone that would actually take that person to make sure that the care is completed is something that's important. But that takes commitment. It also takes resources to have that done. And so we have to advocate for more of those types of funding.
And Dr. Brown? Yeah.
Well, first I commend you. I started my career at an FQHC, and it is really challenging. We have to talk about the business case, we have to talk about systems, and we have to talk about the ROI. So for every dollar you spend increasing medication adherence, you receive it's $7 back. So we have to think broadly, but we have to make the business case to the C-suite who is deciding whether the clinic needs a health coach, a community worker who can make those make that connection. And we have to tailor the message. We also have to pay attention to the pressures from regulatory, right? So Dr. Kalyani, going from 10 to 9 or 11 to 9 has a greater impact on the health of that patient than going from 8 to 6. However, if you're primary care and you're in a system where you wake up in the morning, you turn on the computer and you see that your numbers, are over 8, you're dreading that patient are you going to spend that extra amount of time that's needed to get that patient? We can change the regulatory burden and some of we can switch it at a national level so that we are encouraged to spend the enormous amount of time to get from 12 to 10, and that person is going to be better off for it.
So I'm looking at our time. I want to go to this gentleman on this mic so that you can ask your question. If you just tell us who you are and what your question is, please.
Deepak Mittal, I'm a transplant surgeon from the Chicago area, and you may be wondering what I'm doing here. Well, I just joined.
Wait, what type of surgeon?
Kidney transplants.
Okay.
I used to do pancreas in the past, and if you're wondering what I'm doing here, well, I just signed up for the AMA, and they said I could come to this conference. Actually, I'm glad I came here because a lot of my patients are minorities. And then what we see is when everything fails, dialysis is the end stage for a lot of people with diabetes, not diabetics, with diabetes.
Yes, good job.
They come to see me. And, and we do a transplant, adherence is important. I used to work at Rush, Dr. Brown Mayman, I remember me, left Rush after 15 years. So I think, Dr. Stanford, I'm going to put you on the spot.
Okay, let's go.
Because
I'm ready. But I'm going to talk about obesity, so we're going to get back to my favorite topic. But
exactly, because we're putting the forest, counting the forest trees, whatever, because prevention. And you know what they say, everything you need to learn in life, you learn kindergarten. So if we teach all our kindergartners to avoid the soda and the pop and get obese, which is an epidemic, they won't end
Well,
up.
remember, we got to get first people first language with obesity, right? So just like Dr. Kalyani, so with obesity, we're not going to refer to them as obese patients. They have obesity.
Did I say that?
You did just say it. I was
Darn-
listening.
darn it.
You guys heard it.
All right.
Okay, I'm listening to you.
All right, people with obesity,
Yes.
right? So if we, an ounce of prevention is better than a pound of cure, right? All those Catholic school things I remember.
Yeah.
So that's what we need. We need to prevent diabetes.
Absolutely. I guess the question that he's asking is, why aren't we spending more on prevention? I absolutely believe prevention is important. My career started in public health. I did my master's in public health, worked at the CDC, I worked at the American Cancer Society. But one of the things that I think that we often forget when I look at my public health colleagues is that we have these patients that already have the disease. If we're looking at something like obesity, for example, 94 million Americans have obesity. So we can't neglect the fact that on the ground, we're dealing with the largest health crisis that we've ever faced here in our country. We have to treat those individuals. Much like we must treat those individuals that have the disease of obesity, we must treat those persons on the ground at the public health center, the free clinic in Pennsylvania. At all of these centers that we hear, the academic centers, we must treat those individuals that already have this diagnosis of type 2 diabetes. Now, would love to prevent it. We can reduce healthcare costs by preventing it. If we treat obesity, which we know to be one of the major causes for type 2 diabetes, we can definitely avoid some of these costs. But let's focus on what we can do to treat these individuals that we know are struggling with this disease of diabetes, and do what we can to make sure that they get the adequate treatment they need to improve healthcare outcomes. So that would be my answer. Did you like that?
I love it.
Okay, thanks. All right, so I'm going to come back over to this mic, and can you introduce yourself and your question, please?
Yes, good afternoon. I'm Mary McGowan, CEO of Women Heart, the National Coalition for Women with Heart Disease. First of all, I'd like to thank you for the extraordinary work that you are all doing on a personal level. My father had diabetes, went through multiple amputations, and ended up as a double amputee. So the work that you're doing is extraordinary. In terms of women heart and diabetes, we're trying to raise much more awareness about the link, of course, between cardiovascular disease and diabetes. And so I'd be curious to hear some of the work that you all might be doing in that space to elevate the comorbidities associated with that, particularly as it relates to minority women. Thank you.
Excellent question. Anyone on the panel? Yes, I'll start with Dr. Kalyani.
I think, this will feed into the previous question as well in terms of prevention. So one of the things I just want to say about prevention is you talked a lot about obesity as a modifiable risk factor for diabetes, but family history, which is often tied into race and ethnicity as well, is also a very important risk factor. So I think at the level of prevention, really educating women of minority backgrounds in particular that if they have a family history of diabetes, that they are at an increased risk. If they have a history of gestational diabetes, we haven't talked about that on the panel, but for women in particular, they have a 40 to 50% lifetime risk of developing diabetes. And so I think that transition from prediabetes to diabetes is an opportunity to prevent the burden of cardiovascular disease in women by preventing diabetes from being diagnosed in the first place. And then the second is understanding that prediabetes, just because it hasn't been talked about yet, is a disease state of itself associated with cardiovascular disease. And so I think there's many opportunities along the continuum of the disease for us to educate women, minorities about cardiovascular disease. I'll just say from the guideline perspective, cardiovascular disease, our chapter exploded this year. If you have a chance to take a look at it, and part of it was driven by the cardiovascular outcome trials, which really showed that not many, but some of the drugs have specific cardiovascular benefits that aren't related to their A1C or blood sugar lowering benefits. And so I think that link between cardiovascular disease and diabetes, that awareness is only going to grow, but getting that to the population that needs it is going to be a challenge.
Yes, well, I'll start with Bruce and I'll come down. Yeah, Bruce.
There's a great collaboration that's occurring now between the American College of Cardiology, the American Heart Association, and the American Diabetes Association. They're all starting to recognize is that if you have a diabetes diagnosis and you're older than 40, you got it all. And they got to try to figure out how do we treat the patient, because unfortunately you can't segment it by population and say, here's everybody with heart disease, here's everybody with diabetes, here's everybody with hypertension. We're all one and the same. So there's a whole new collaborative effort amongst those organizations to say, how do we better coordinate and communicate? Because your blood sugar and your lipids follow each other and is directly correlative if you're going to have the second heart attack or you're going to reocclude after an interventional cardiovascular event. So they're starting to recognize, how do we join forces to treat the patient and not the disease specifically?
I'm going to go to Dr. Fraser and then back to Dr. Brown, and then we'll move on to the next question.
So years ago we developed a curriculum or training curriculum to train stylists or lay health people to talk about cardiovascular disease. And we also, at the same time, had people talk about diabetes. We kind of linked both of them together because we knew that you needed to talk about diet, and we wanted people to know their numbers. So in knowing all of their numbers around cardiovascular disease and their numbers around diabetes. But what we found that things needed to be culturally tailored. So when we were talking to people about, improving your diet, the how-to is important. So I come from a Caribbean background, and a lot of the people we see in the community might be Afro-Caribbean. And when we're telling them, we want you to cut down on salt here and cut down sugar here, what does that mean? How do I change the foods that I currently eat and make them taste well enough that I would want, and they're still appetizing, so I would do that. So what we would do would actually have classes within the salons and barbershops where they'll have cooking demonstrations and how do you substitute things so that people can see it in real time, what they can do to make those changes.
Dr. Brown?
Real quick, in my, to follow up, in my office I have a 20-ounce empty bottle of soda, and I put in the amount of sugar that's in there. Because if you ask type 2 patients with type 2 diabetes, is orange juice good for you? They will say yes, because they watch Steel Magnolias, the movie Steel Magnolias. Right? So I mean, the gap is just enormous. So I don't have to say anything. They look at it and if you stop drinking one of those a day, you lose 20 pounds in a year, and they can't believe that. But from a systems approach, 1,600 guidelines in 17 minutes is what a primary care doctor, family practice, internal medicine is dealing with. So no one just has diabetes. The comorbidities are numerous. And we're here at the Ritz talking about this, but on the next block, somebody is raising another issue. So blood pressure, hyperlipidemia, all of that, right? Most people have it all. And we have to change the workflow so that we can address all of these and have time enough to develop a relationship with the patient so that we can tailor our message. And right now, the work of the AMA and Burnout is really trying to push back with a free website called stepsforward.org to change the workflow, to change how things have moved to do for the clinician to have more on their plate so that we're turned this way to the computer and not that way to the patient. So we have a lot of work to do, but a lot of organized medicine is really trying to think about the whole patient and not just one number.
So this is going to be the last question. We've got 3 minutes and 42 seconds left. I'm going to go back to this mic. I am precise. You guys have no idea. It drives my husband crazy. Can you say your name and what your question is?
My name is Joy Cornthwaite, and I'm a registered dietitian and certified diabetes educator. I work in McGovern Medical School at UT Health in Houston, Texas. And I'm just going to try to be succinct because I am super passionate about diabetes.
And you know I'll cut you off.
Yes, and I know that too. I'm very frightened. So one of the things that I keep hearing as we go to different sessions, I am blessed enough that I worked for the DOD and the VA. And now I work for McGovern Medical School. And there's this, kind of, our physicians are determined to give our patients complete and total care. So I understand that I am very lucky in that, but some things that I keep hearing from clinicians is how do you establish those connections, or how do you encourage people that you work with to establish those connections when they're not readily available as they have been for me?
Does anyone on the panel want to address establishing connections with the clinician or with the resources or a combination thereof?
Both.
Okay.
Clinician to clinician for referrals, and also resources in the community when you don't have the support systems that I've had.
So coordination of care is what you're talking about. Bruce?
I wish David Marrero was still here, because David is at the University of Arizona. He's looking at border communities, underserved Latino communities with diabetes. When you say community health worker, some people cringe, but Dave is sort of a pragmatic guy and say, if it isn't working, why are we continuing to do it? And one of the things that he found is that with the promotores, they're trained community health workers that have enough basics, but you know something, what I learned in McAllen, I was a good gringo, but I was still a gringo. But they trusted Maria, who was from their community, who went into their home. And that's how they connected. So when they called me good gringo, I'm saying, was that good or bad? They said, no, you're accepted, but you're still a foreigner to them. But when you get to the community, because even in that culture, they don't trust their physician. They do to a certain degree, but they trusted Maria. And if Maria says, I want you to go see Rita to get checked up, or Dr. Brown, guess what? Maria would take him to the visit. She would do the translation. She would pass the benefit of the relationship. And I think those are real basic pieces to get members of the community engaged with the members of the community.
All right, we have 45 seconds. Who would like to close it out for us? Yes, Karin.
Add one thing that Joy actually well knows with the work in Houston, and that was trying to do things on different fronts. So we worked with the faith communities and trying to bring education, diabetes prevention into the faith communities. Houston got together and tried to increase their peer support capacity so that people with diabetes could hear from their peers about how to manage their disease or what resources might be available. And then also establishing this website where there were trained community health workers who acted as navigators. So kind of trying to push the system in as many places as you can where people may not trust the formal health system or may need to hear it from many different places in order to be able to act upon it.
Well, we are 6 seconds over. I would like to give a clap to the panelists. I would also like for you to give yourselves a clap for these wonderful questions. It is my understanding that we're going to a lovely break right now. I will ask the panelists to at least stay around because I think that there's some burning questions that you guys might have. Thank you guys so much for your time and attention. Have a fabulous day.